Hello and welcome to Dragon Bytes, the paediatric podcast aimed at paediatric trainees or anyone interested in child health. I'm Asim, one of the paediatric trainees here in Wales and one of the presenters for Dragon Bytes. This week we've got our second half of the talk on HIE from Celyn Kenny, one of the presenters of Dragon Bytes, and Dr Elisa Smit, one of the consultant neonatologists at the University Hospital of Wales. Anyway, let's get started.
So if the heart's had an ischemic hit, it's going to not pump as well as it's supposed to do. So you often see hypotension then. So many of those babies end up on inotropes for a period until everything recovers again. And most organs are extremely good at recovering following HIE. It's just the brain. But once the damage is there, it's harder to recover. And that's why we do the cooling treatment. So yeah, from cardiovascular point of view, I usually say keep your mean blood pressure at least 45 or above because these are term babies.
And so central access.
Yeah, definitely. It's just going to make it so much easier to monitor your blood pressure.
And kind of for the baby with sampling.
Again, sampling, yeah. With cool babies, often the peripheries aren't very well perfused. So yeah, you definitely want to get good samples from the lines, definitely. So yeah, we covered respiratory, cardiovascular.
Neuro with the pain.
Yeah, neuro and pain.
And obviously they're on the CFM and treating the seizures. Another thing that as a trainee for myself, and it's more the nurses educate you, is the subcutaneous fat necrosis and the importance of turning them.
Yeah, definitely. And there's different types of mats available as well. So subcutaneous fat necrosis, we don't really know why it happens, but it's sort of crystallization of the fat underneath the skin. It's a very painful condition, and it can also lead to hypercalcemia. It might be inherent to the hypoxic-Ischaemic insult rather than due to cooling. So the case report started appearing when we started cooling babies, but we wondered if that was due to the fact that we're just better at sort of looking after these babies and giving them full intensive care and we're actually realising what's happening. It's often dependent area. So if they've been lying on their back a lot, you do see sort of over their shoulders, sometimes armpits. So yeah, that's why it's really important that nurses keep turning the baby, but make sure they stay in contact with the mat, but keep checking their skin regularly.
And you said about the calcium, so correcting electrolytes.
Yes.
So monitoring bloods and things throughout cooling.
Again, there's a lot of confusion about the sort of cooling bloods and what to do, but it's just important to regularly monitor their bloods. I often say your admission bloods, do a full set of bloods, and include all your renal function, your liver function. It's not something we often do straight away, because we always say what reflects the mother's sort of results, but on the other end, you want something to monitor because some of these babies actually go into proper renal failure. So knowing your starting point of creatinine, you can then see with the next point, like has it gone worse or has it gone better? Same for all your liver enzymes. It can help you to decide when the insult actually happened, because the insult could have happened 3 or 4 hours before the baby was born, or even a day before the baby was born. We don't always know when this insult happened. So if you see all the enzymes and all the organs sort of in the first 12 hours peaking and then get better, it probably means that the insult was around the time of birth. I remember 2 cases, I think, where everything had normalised. Like we never saw any peaks, but the baby behaved like a severe HIE. That made us decide that this insult was probably 1 or 2 days ago. It's happened antenatal and everything's pseudo-normalised. Like by the time that baby was born, we could still see the brain effects, like the baby was encephalopathic, but all the other organs had sort of semi-recovered. So there was something that had happened days before the birth. So it does help you, and especially in medical legal cases, this sometimes becomes a problem, knowing when the insult happened. Like, could something have been recognised, and could that baby have been delivered earlier? So that's why it's so important to do bloods regularly. So I usually say sort of at birth and then 6, 12, 24 hours in the first 24 hours, and then probably daily or dependent on the situation. I mean, if you're dealing with a baby that's seizing, you're probably going to be rechecking your calciums and your sugars and your magnesiums a lot more often because you want to make sure they're all in the normal range.
And do you do a cranial ultrasound as well as part?
Yeah, so again, if we think about differential diagnosis, there are other things that could cause you to be encephalopathic at birth. So it will help you to just do a baseline head scan in the first sort of 6 hours in a period where you're deciding to cool to make sure there's not a massive IVH. I mean, it's unusual in term babies, but they can have massive bleeds, especially babies with sort of underlying clotting problems. A stroke can mimic encephalopathy. Quite difficult to see on an ultrasound, but you may get some indication that there's some unequal brightness or some asymmetry. I've seen babies with big sort of intracranial bleeds, not intraventricular, but either parenchymal or subdurals, that have led to a midline shift on the ultrasound. So it can give you some clues about what's going on. If it's just baseline, sort of basic HIE, you're probably not going to see a huge amount on that early scan. But the one thing that's really important to look at is resistance index. So you're going to be looking at the Doppler flows in the anterior cerebral artery. And the resistance index within that often goes down in babies with HIE because they've completely sort of lost the control in their brain. And sometimes the cardiac output isn't great because of the cardiac insult. So you see really low Doppler velocities in the brain as well. And keep doing that throughout cooling. So I often say the sort of in that first 6 hours when you're deciding to cool, just to make sure there's nothing else going on. And then we do it at sort of 24, 48, 72 hours and after cooling, just to monitor progress. And often what you see throughout cooling, the brain will become a little bit edematous. So the scans will become a little bit fuzzy. That sort of 24-hour one, you might see a bit of fuzziness. It's quite tricky to sort of get a clear picture. That's often due to edema, or the ventricles just completely shut. You can't see them anymore because of the edema. You can see in the severe babies, the main region that gets affected is the basal ganglia and thalami, and they can start to look quite bright. That takes some time. So it's often day 2, day 3, or even after cooling. And that's also the areas they're going to be looking at when the baby eventually gets an MRI scan. But definitely the baby with severe HIE have managed to see the exact same changes that we saw on MRI on cranial ultrasound as well.
You mentioned as well the RI, the resistance index. That is a prognostic factor,
It does help
as well?
in prognostication. Yeah. I mean, there's lots of things we can take into consideration when we're thinking about these babies' prognosis, but RI is one. So, and the one that's currently the only one that's sort of predictive is the one post-cooling. So if you've still got a very low resistance index, sort of below 0.55, after you've been rewarmed, that is sort of puts you in a really high risk group of babies for having a poor outcome, unfortunately.
And so the baby's been cooled?
Yeah.
And what's the maximum time they're cooled for?
Yeah, so we normally say 72 hours because that's what all the trials did. Occasionally during rewarming we see some problems, and then we may decide to either hold the temperature or recool again. And the two problems we see during rewarming are either hypotension, and because we are warming the baby up, so sometimes it just become a bit hypotensive, and they may need a fluid bolus, and that gets itself sorted, or seizures. So particularly babies who had a lot of seizures during cooling often don't cope very well with rewarming. So those babies we may cool a little bit longer, or just hold sort of warming them up a bit more until we're under control, and then we continue rewarming. But the standard treatment will be 3 days. And actually people have now trialed in humans, so in babies, 5 days of cooling. And it was actually a trial called the Longer, Deeper Cooling Trial, where they thought, well, let's try cooling deeper. It might do even better. So they cooled down to 32 degrees and for 5 days. So they had 4 treatment groups in that trial. The standard one that we do, 33.5 for 72 hours. Then one group that was cooled to 32 degrees. One group that was cooled for 5 days, but at 33.5. And then the fourth group had both, so cooled longer and deeper. And actually, for all those groups, the mortality was higher, and the highest mortality was in that last group that was cooled to 32 for 5 days. Okay. So that trial was actually halted before they recruited all their patients because of the clear safety concerns. They haven't published, as far as I'm aware, they haven't published their long-term data because obviously those babies that survived, they would have followed up for 2 years. I don't think I've seen the data published yet, so that'll be interesting to look at.
Something to
but from that trial, I mean, if you've got higher mortality, you can't continue. So it looks like we've probably chosen and extrapolated from all the animal data the correct time and temperature.
Yeah. And so we're now rewarming the baby.
Yeah.
And what we've mentioned about the seizures and the hypertension, are there any other things that we need to be doing? Is there a desired time that the baby needs to be rewarmed?
Yeah. So as we start cooling, we do it very quick. Rewarming is slow. So, and it's something really important to tell to the parents as well, because they
just want that cuddle.
Cooling for 3 days, and now you can start rewarming your baby, and they think all will be fine in 2 hours. But actually, we want to rewarm slowly to avoid all the problems we've just been describing. So we say about 0.5 degree an hour. That's going to take you 7 to 8 hours before that baby's back into the sort of 37 degrees. Then we take the cooling mat away, but often those babies struggle to maintain the temperature. So again, I teach the nurses a lot to just continue monitoring the rectal temperature once the baby's reborn, because often they do struggle a bit to maintain the temperature. But it's a time when we often start to wean down the ventilation then if they're ventilated, wean their sedation, and sort of work towards extubation, starting feeds, and sort of normalising the baby and see what they're like following cooling.
And some babies, obviously, who have been cooled go on to have MRIs.
Yeah.
So following the rewarming, the establishing of feeds, usually we do it within the first week to 2 weeks.
Yeah, correct. So it's quite important to not leave it too long, because some of the signs disappear after a while. Like if you've got very severe changes, they're going to stay there. But there's some crucial signs that you'll only see sort of from day 5 onwards. So we usually say day 5 to 10 is quite a nice period to do it. BAPAM have actually recently published a new cooling sort of framework, which has a whole long new section on MRI and sort of sequences to do as well. And they've suggested doing something called MR spectroscopy, looking at sort of the lactate ratios in your brain and things like that, which again will help with prognosis, because that's all the parents want to know at this stage now, isn't it? They've managed, the baby survived, they've gone through cooling. What will their baby be like when they grow up? And obviously that is the $1 million question.
Exactly.
It's a really difficult one to answer. Yeah. And that's what MRI does help. So if you've got very significant changes on MRI, I'm going to have that conversation with the parents that talks about cerebral palsy, neurodevelopmental problems as that baby grows up, maybe ongoing seizures. We do get babies that go home on anti-epileptics because they continue to seize despite their cooling treatment, for example, or they're seizure-free for a bit, but then the seizures return because obviously if there's damage in the brain, that is one of the signs you'll get as they grow up.
And what I think is brilliant is that some charities now, like Bobath, will offer input from the get-go.
Yeah, indeed.
If these babies have been cooled, there's a referral system for parents to do online, or yourselves as consultants, which I think is great.
Yeah.
And I think it must give parents some kind of hope and just know that they've got something in place.
I mean, it's one of those things, isn't it, where you're giving them this awful worst case scenario, really, when a baby's born. We think your baby's got brain damage. We're going to give them some treatment in the hope that we can stop some of that damage happening, but the damage that's there, you can't really reverse. So it's one of the hardest things, I think, for the parents as well. So building in that hope, that really high vigilance. So the first 2 years, those babies will be really regularly monitored in clinic. They'll have physio input, OT input. I mean, not all hospitals have OT. Where I work, for example, we've been fighting for years to get some OT input and we're still failing. But there's many units who've got a lot of support for these babies. They come back to clinic and often the parents need that first clinic appointment to sort of almost debrief about everything that they've gone through, because it's only when they go home they start to realise everything they've gone through. It's really important to stay closely in touch with these families and follow them up until they're 2. And some, actually, when it becomes very obvious they've got a lot of damage there, we think they're going to have cerebral palsy. We do include, Bobath therapy, for example. Especially in Wales, we're really lucky to have the local therapy here. But our physios are really closely involved. And then we often, if I think that is the case, they often involve the community paediatric team early on, because they've got a whole MDC there then, and get to know them early.
And get to know the parents, and they've got the support
family.
Network there.
Exactly.
Because a child is very different to the baby.
Very true. Yeah.
Just to bring this really interesting talk, it was fascinating. I've really enjoyed to a close. Is that what can we look out for in the future? I know we've spoken about the recent trial about the 5-day cooling, which has been halted, and the looking at the lactase on the MRI. Is there anything new else on the horizon that we can
There's quite a few sort of hot topics in cooling. So the difficult one is, what do we do with some of the babies that we think they may benefit from cooling, but we're not sure yet? So that's your late preterm babies, so those between 34 and sort of 36 weeks, or we feel like, well, they've had a clear HIE insult. Should I give them cooling? But obviously there's some risk with that, because those babies are still preterm, so are they potentially at risk of IVH, for example, if I start cooling them? So that data isn't out there yet. There's an RCT running at the moment in the States, but are very slow to recruit because of the numbers of preterm babies with HIE are not as big as the term babies. So I think that is slow to recruit, but hopefully in the next 5 or 10 years we'll know the answer to that one. And we may start to include babies down to 34 weeks, for example. Another big group is the babies with mild HIE. So that's not stage 1. The mild HIE babies, what do we do with those?
Yeah.
And we just don't know at the moment. We know that their outcome is worse if we don't give them cooling. What we don't know is, can we improve that by giving them cooling? Or are we making it worse
by cooling
them? We just don't know at this stage. So again, there's no formal RCTs published yet. There's case sort of cohort studies where they've compared babies that with mild HIE that were cooled compared to term babies that were cooled, but you can't really compare the two. You can't compare a mild with a moderate HIE because their outcomes are different. So I think there's a lot of work and a lot of trials starting in that field, definitely.
So watch this space.
Definitely. And then on top of that, there's all the sort of, yes, we've got cooling treatment, but are there any other treatments that are going to help these babies? Because it's still a devastating prognosis they're having to give to the parents. So despite cooling, it's still about a 50% poor outcome. There's still about 25% of babies with a neurodevelopmental problem as they grow up, and there's still mortality as well. So there's lots and lots and lots on the horizon, ranging from stem cells, which are hot, whichever condition you look at,
across the board,
to sort of add on pharmacological treatment. So melatonin has been spoken about, EPO has been spoken about. There's a big trial running in Europe with allopurinol called the Albino Trial, which I think they're recruiting really well. And that is giving allopurinol as a sort of free radical scavenger.
Okay.
And those treatments you could give really early on. You could literally, as the baby's born, or you could even give it to the mother when you think there's something happening. And it's just 2 injections, so much easier compared to 3 days of cooling, for example. So all these sort of new treatments are being trialled in addition to cooling. So no one would ever now go back and just trial those on their own. The final one that I've myself been really involved in is the Xenon Trial, where an anaesthetic gas called Xenon was added to the cooling treatment. Again, we're still analysing all the data for that one. Watch this space. But it's quite a difficult treatment to give because they obviously need to be on a ventilator, because Xenon is a really rare gas. Yeah. It's quite expensive, so you have to have a special ventilator that recirculates the Xenon all the time. So it's not a straightforward treatment to do. But yeah, lots of exciting things out there on the horizon.
Oh, I look forward to it.
Yes, well, I'm sure in your careers you'll see one of them at least. That's what I really hope, that we'll have more clarity.
Oh, Elisa, thank you so much for joining us.
That's okay.
Hopefully we can hear more from Elisa soon on other neurodevelopmental topics and neonatal medicine. So thank you all for listening.
And I just wanted to say thank you to Celyn and Elisa for recording that for us. That was really helpful, and hopefully we've all learnt a little bit more about HIE. Join us again next week for another episode of Dragon Bytes.